الفقد العظيم لابن أحمد الريح الذي غاب عن دنيانا في إثر حادث حركة، ونعاه المشيعون بمختلف أجناسهم وطبقاتهم، وكان لغوف زملائه الطلاب والأسرة السودانية بتنزانيا وسفارة السودان الأثر الكبير في تخفيف هذا المصاب علينا. ونحن إذ ننعيه نحس بالحزن والأسى أنه غاب عنا في بلاد الغربة، ولكن سلوانا أنه مات شهيدا، لأنه مات في طلب العلم. فنحن نسأل له الرحمة، ونسأل لآله والأسرة جامعة العلوم الطبية الصبر والسلوان، ودعاءنا له بأن يتقبله الله. هذه المحاضرة هي التي أجلت من الأمس، وهي عن شيستوسومايسيس. هذه محاضرة وهذا موضوع نحن يعني نحبه. Schistosomiasis is a disease which has witnessed great development due to research. So the research in 30 years or 40 years have completely changed our view, our understanding of the pathophysiology, of the physiology, of the diagnostic abilities, and more important, on the drug therapy of this disease. We were talking about toxic drugs in the 1970s, like tartarimetic, which may affect the heart, the joints, and the kidneys, and may kill the patient even before killing the parasite. But now we are talking about single drug, which can be taken orally in a single dose and can do miracles, not only treating the adult worm, but also can be used in mass chemotherapy to eliminate the disease. So here we are talking about a disease with great successes led by evidence-based research and evidence-based medicine. To me, schistosomiasis is near to my heart because I have not only witnessed the progress of science and development in that disease, but also I have been blessed by being partner of many of these development in research in schistosomiasis. So I would like to just run through what is important about schistosomiasis, and particularly I love to tell you young generation, about the history of schistosomiasis, particularly pointing to your predecessors, to your fathers, grandfathers, who are scientists who have really impacted on the knowledge of schistosomiasis, so that you should feel proud that you are coming from those who have contributed not only to the knowledge in Sudan, but to worldwide knowledge. If we just mention as an introduction, what is schistosomiasis? Schistosomiasis is a disease caused by fluke, blood fluke, or trematode, which the adult worm lives within the vessels so that it is wriggling with the flow of blood, but it is hooked to the endothelium of the veins. So that is one important aspect. And it lays eggs which penetrates through lytic substances. It penetrates the viscous B bladder in Schistosoma hematobium, or colon in Schistosoma mansoni and japonicum. It is stressed that the pathology of schistosomiasis is only caused by the eggs. I repeat, the schistosomiasis pathology is only caused by the eggs, nothing more, nothing less. The adult worm, although living in the blood vessel, and it matured within the portal system, the portal tract, but it causes no damage. It's only the damage which is caused by the adult worm is through the laying of thousands of eggs per day. So that is the pathology. And you should remember, as an introduction, that it is water-related infection, meaning that there is an intermediate host, which is called the snails, lives in stagnant water or slowly moving water, like in canals, irrigation canals, with mud and vegetation. So it is related to water and contact with the water. Then we talk about if there is any animal reservoir. As far as hematobium is concerned and Mansoni is concerned, the man is the only host of these parasites or trematodes. When we talk about Japonicum, then that is another story whereby dogs or buffalo or cattle may be an intermediate host as well. For control of schistosomiasis, you could summarize it in two facts or two factors. One, safe sanitation, adequate sanitation, that people would not fill the air to empty their bladder and bowl near the water, because we have this habit that during the water to be able to wash ourselves after these acts. And this is what brings the healthy individuals to the canals, because they wanted to wash, so they wait. And children may find it pleasurable to swim in the canals. So it is safe water. If you have safe water, if you have adequate sanitation, then schistosomiasis may not appear. That is very important. So it's a public health problem. It's a public health scourge, which can be easily controlled, said and done easily, but it needs a lot of effort. On the good side, it's been considered one of the neglected tropical diseases. That is to say, these are the diseases which are not being given enough attention by countries and World Health Organization. This has changed in the last 15 years, has changed. And it is now considered one of the diseases which can be easily controlled and targeted by WHO as to be controlled. Because of our understanding of the pathophysiology and the effect of the drug. The drug is very effective, it's safe, can be handled by volunteers rather than nurses or doctors. So it is within the capability of every country to distribute that drug on a regular basis, yearly, that will control this disease. And it has been noted that quite a number of countries, I could mention 10 or 15, who had schistosomiasis being under control as a public health problem. So it is possible. The unfortunate fact, as far as Sudan is concerned, schistosomiasis is an old disease since 1925 or even more, but it continued to be a health problem, and it continues to expand in many areas. Has not been known to harbor or to be endemic with schistosomiasis. And this is something which calls for attention of the health authority to control schistosomiasis. So it's everywhere in Sudan, almost everywhere. Classically, it's in the Jazeera area where the irrigation is, and in all the areas which has been irrigated by new dams. You know, Khashm al-Girba, which is Halfa Jadida, is a dam which was constructed in the late 50s and 60s. And the Halfonians, Halfawiyin, were brought from Halfa because it's been drowned by the high dam of Egypt. And was brought to area of Halfa, and they didn't know schistosomiasis before. But once they were in the new scheme, they developed schistosomiasis. More so, all the ponds, okay, and lakes of Sudan has been infested with schistosomiasis. Along the Nile, in between Jabal Awliya, north to Durman, these are the areas which now infested heavily by schistosoma hematobium. And you will say, where is the canals here? The canals are these ponds when the water flood, the Nile flood, and then recedes. Then it leaves areas, big ponds, which can be infested easily with schistosomiasis, especially children playing there, urinating and defecating. Lakes like Rahad Lake, which is in Kordofan, west of Sudan, and other areas in Nuba Mountains and in Darfur area, particularly in the south, again, it's very heavily infested. So I think it's important, a disease for every clinician, and I will say every clinician, because it's not only internal medicine like us who will deal with schistosomiasis. It is every clinician practicing, and I will come to that. The big dams in Africa also has been infested by the irrigation canals and schistosomiasis. Are you with me there? Bara, Nada, Ahmed, are you there? Shall I continue or you're cut off?
سامعينك يا دكتور.
طيب كويس. Okay, so the big areas. We talk about 5 species of schistosomes. This is hematobium, which has a terminal spine, Mansoni or Mansoni, okay, which is intestinal, mainly colonic schistosomiasis, and Japonicum, which is the whole bowel, which is small bowel and large bowel, but this is restricted to Southeast Asia. And then we have Schistosoma Mekongi, which is along the river of Mekongi River in Southeast Asia. And then Schistosoma intracalatum, which again in Central Africa and West Africa. The last 3 are the intercalatum, the Mekongi River, Mekongi schistosomiasis. These are very minor species, minor infections. If you are to remember the species, you remember the hematobium, the Mansoni, and partially the Japonicum. Even Japonicum now in many parts of Asia is now being controlled. So these are the species of schistosomiasis, and areas may know Schistosoma mansoni for a period, but then transformation occurs, and then suddenly you get Schistosoma hematobium. So it is something which, because that is very important in the pathophysiology. If we are infested with Schistosoma mansoni, we are dealing with mainly gastrointestinal abnormalities, okay, colonic abnormality, liver abnormality. But if we are dealing with Schistosoma hematobium, we are dealing with urinary schistosomiasis. And I'm using the word urinary just for once. It's not called any longer urinary. It is genitourinary schistosomiasis. Now, it is recent research have shown that hematobium is a source of diseases in females' genital tract and males' genital tract to the extent that it leads to an ectopic pregnancy. So it is called urogenital tract, urinary, and genital from the genital tract. So please use this term instead of urinary schistosomiasis. So, and the disease is waterborne because unless you have snails in the water which produce the infective form, then you wouldn't have schistosomiasis if you don't have snails. So the cycle of the disease is you have people, usually kids, urinating and defecating, giving genitourinary, or defecating, giving mansuri, which is the mansuri infection, in the water. They excrete eggs. Or the eggs are passing through the urine and passing through the stools, and the eggs will remain in the water for just the warmth of the water. It hatches, leading to a ciliated motile embryo. Ciliated, it just get excisted. The embryo comes out, which is called miracidia, M-I-R-A-C-I-D-A-C-D-I, miracidia, which is the ciliated motile embryo. This will remain in water for maximum 2 days. If it doesn't find a snail, then it will vanish, it will die. But once it gets into the snail, then it multiplies. It multiplies for 2 months, then producing the infective form, the infective embryo, which is called cercaria. Okay? And the cercaria had a head and a tail. And the tail is forked like two pieces, like a fork, like a shoka. And this makes it swim in the water and finds a healthy person. It penetrates inside, but leaving the tail outside. So the tail will get dropped outside, and only the head of the snail will get inside the body. And here it is called schistosomiole. Okay? There, this schistosomiole circulates, and for a day, 12 days or so, it gets finally into the portal system. In the portal system, the growing worm matures in the portal system. Just imagine, in the portal system, where our food is all driven from intestine through the portal tract to the liver, forming proteins, albumin, and other things, and the feeding is then the fatty acids and the cholesterol are all formed. Within that blood, we find worms which are maturing to adult worms. Okay, once the adult worms are mature, they are around about 2 centimeters. Okay, and unlike other worms where the female is big and large, here we have the male being big, and it has a leaf-like edges, and what it does, it folds itself into a groove, from the two edges of the worm. It forms a groove, gynecophoral groove, gynecophoral from gyne, because there in that groove rests the female, and the female rests in that groove, mating with the male, and then once it is full of eggs, then it comes out and then goes into the peripheral radicle of vessels. In Mansoni, it goes to the peripheral vessels around the colon, and in the hematobium, it goes to the peripheral vessels around the bladder. So it is a disease of colon primarily in Mansoni, and it is a disease of hematobium, disease of urinary and genital system, because that is where the eggs are being laid. So this is the adult worm, and it's in the gynecophoral canal, and this is called schist, S-C-H-I-S-T. Schist in Latin is a groove. This is why the name came Schistosomiasis, because of this groove of the male, okay, which is a groove, a schist, where the female comfortably stays to mate with the male and produce the eggs. The female eggs produces thousands of eggs per day, thousands of eggs per day. And these eggs they come out, or touch on the bladder, or the outside of the bladder, or the colon, and secretes lytic substances which dissolve the tissue and helps the eggs to penetrate the wall to get inside the lumen, And what happens is that 50% of the eggs can find their way into the lumen. And paradoxically, these are not the eggs which is causing the greatest harm. The greatest harm comes from the eggs which are either trapped into the submucosa, they don't go out, or are being carried ectopically by the blood in the portal system or in the other system to be deposited distally into other tissues. So the pathology, if you penetrate, you can cause an ulcer in the colon or in the bladder, you can cause bleeding, and you can cause some difficulties in these places, like you get a dysentery, you get blood in stools, and so on. But the other 50, part of it is trapped within submucosa, which then develops pathology. Okay, we'll come to pathology of intestine and pathology of the bladder. This will cause local problems, but then the biggest damage comes from the eggs which are released in the portal system and in the systemic system, which goes further into other tissues. And in Mansoni, the eggs deposit in the liver. And if the single most important complications of schistosoma mansoni is hepatic fibrosis, what you call hepatic periportal fibrosis. Hepatic periportal because it's the fibrosis is around the portal tract and strangulates the portal radicle, okay, closing it. This is why we call the liver hepatic periportal fibrosis. So the single most important complication of schistosomiasis is liver disease, and mainly hemodynamic disease, causing portal hypertension because of the fibrosis of the portal radicals in the liver. The hematobium on the other side causes the eggs which are deposited within the tissues of the bladder and within the genital tissue, okay, causes some problems or pathology. And the one which goes distally, it goes in the systemic circulation. So that is about the parasitology, the cycle. And when you come to pathology, actual pathology, if we talk about genitourinary schistosomiasis, the eggs, as we said, the disease is mainly of the bladder, but it affects other tissues in the pelvis. Okay, what happens is when it penetrates the bladder, it causes ulceration. And this ulcer then may heal, but it causes bleeding. And then may have polyps. The eggs may cause polyps, and these are C-sized polyps. And then as chronicity, granuloma forms, and every pathology in schistosomiasis starts with the eggs and then the granuloma, which is formed around it. The granuloma is mononuclear cells, T cells, and it grows into a actual big tissue, which then may heal by fibrosis. So in the bladder, you get granuloma subcutaneously, and this granuloma may cause narrowing, fibrosis, and then polyps will form. And to the extent that it can even, when it burns out or dies out, the eggs, they can cause calcification in the bladder. The areas is erratic. It's irregular everywhere, but mainly in the trigone of the bladder. Okay, so you find ulcers, you find polyps, which are sessile polyps. You can find calcification. You can calcification. And the most important sequelae of vesical schistosomiasis is development of carcinoma, squamous cell carcinoma. And this is a very serious complication of schistosoma hematobium. Normally, the bladder is susceptible to transitional cell carcinoma, but the carcinoma which occurs with hematobium infection is of the type of squamous cell type, and this is due to metaplasia. The infection, schistosomiasis, causes metaplasia, and then this can break into the proper squamous cell carcinoma. So you remember that the common bladder cancer is transitional carcinoma, but in the case of hematobium infection, it is squamous cell carcinoma. So that's as far as urinary is concerned, but then you get secondary effect. The secondary effect, if in the bladder, around the uretrovesical entry, then if you get around the granuloma, okay, and then heals by fibrosis, then you will either end with a blocked ureter or a patent ureter, very patent, incompetent ureter. So there is reflux of urine from the bladder into the ureter. Obstruction at the lower end of the bladder, of the ureter, as it goes in the bladder, then that narrowing or fibrosis can lead to back pressure on the ureter and cause hydronephrosis, and the ureter it balloons out as hydronephrosis, and then you get end-stage renal disease. Are there any eggs along the ureter? Very rarely you can find eggs, but that is not the main pathology. The main pathology is a back pathology, back pathology, which starts in the urine, in the bladder, and then goes back into the kidneys. As far as the kidneys, just before we close the effect on the kidneys, there is an immune complex glomerulonephritis, which occurs with Mansoni, not with hematobium. With Mansoni, there is an immune antigen antibiotics which causes glomerulonephritis and may go up to nephrotic syndrome. And this has been reported from the Sudan. Dr. Hassan, in the pediatrician, he described these cases of nephrotic syndrome following these immune complexes. So apart from that, kidneys are affected mainly from lower below. As far as genital schistosomiasis is concerned, you can get deposition of eggs in the cervix, leading to ulcerations, in the uterus, also leading to ulcerations, in the fallopian tube, leading to closure of the fallopian tube, and this lead to infertility and ectopic pregnancy. And you get dyspareunia. Dyspareunia is pain when you do sexual intercourse. This is dyspareunia, which is a nuisance, which is a very big nuisance, but the genital is now receiving a lot of attention because this has been neglected before from the urogenital schistosomiasis. Remember that the pathology always starts with the granuloma. And remember that the pathology is caused by the eggs only. Wherever you find eggs, you can find granuloma. The granuloma, I'm sure you have seen it in the pathology, which is eggs in the middle, and then you get a lot of mononuclear cells, and particularly T cells, stimulation, and eosinophils. I would like to mention eosinophils because if you have schistosomiasis active, you get blood eosinophilia. The white count, when it's distributed, these different polymorphs, lymphocytes, eosinophils, basophils, you get higher eosinophils. That is okay. But again, the granuloma contains eosinophils. And if you examine the urine of schistosomiasis, patients with schistosomiasis, then you get a lot of eosinophils in the urine. And Professor Isam Attom, who worked in our group in the 80s, 90s, he described 2 papers, I think, or 3 papers, showing the effect of eosinophils in the urine on the eggs. These are engulfing the eggs, protecting from the eggs being passed in outside or in the water. So eosinophils grow. The eosinophils has a role in the protection against schistosomiasis. Okay, I would like just to go back a little before finishing the pathology and the complications about the history of schistosomiasis. I meant to give the history in the middle because I found that the students, may not get interested in the history of schistosomiasis, but once you get them hooked to the clinical features and the pathology and the treatment, then you can draw their attention well to the history. Okay, the history of schistosomiasis, I like it very much because it tells about a disease which is very old. It is more than 4,000 years in the Nile Valley, And I remember, I mentioned it last time, that the pharaohs' eggs were recovered from their body of schistosomiasis. The hieroglyphic writing showed the features of schistosomiasis, particularly the urine with blood. And when the X-ray was introduced and the mummies are X-rayed, people found calcification in the bladder of these mummies, which is very typical to the egg calcification, which is found in hematobium infection. And these mummies are the kings, the pharaohs. These are farana. These are the kings. So it is a disease which is widespread in those areas, not only in the farmers, but is widespread even in the kings, especially when kings, they go and bath in the water, they wade in the water. So it's a disease which is very old. But recent history will tell us that in Sayyidina Amr ibn al-As, when he came to Egypt and then he ruled Egypt, he wrote to Al-Khalifa Umar ibn al-Khattab radiallahu anhuma about the Egyptian, because once you go into a new area and you want to Islamize the area, you give the demographic characteristics of that area. And one of them is the population. Who are they? What are they? What do they do? And if they have a particular thing which is different, then you will mention it. And it is said that Amr ibn al-As said to Umar ibn al-Khattab, أن رجالهم يحيضون. Obviously, menstruation and haid is that of women, not of men. It is so. He may be referring to the hematuria that comes with the hematobium infection. And even in the culture, the African culture now, people will reach about 10 and then they start giving hematuria. And this is taken by some tribes as analogous to the menstruation in females. And they say men or the children are now reaching puberty. This is up to now, is in some tribes that the hematuria is looked at as something which is growing. Okay, these are the history, the old history. A recent history, relatively recent, 1852, Theodor Bilharz, who is a German physician working in Qasr al-Aini, did a post-mortem on certain farmers who died, and he could isolate, or he could see when he opened up the worms. The worm is 2 centimeters, which can be easily seen, and he described it as the worm which produce eggs that causes pathology. And then the disease was then termed as bilharzia, which from Theodor Bilharz. And now commonly in the Sudan otherwise, we like bulharzia. And misnomerly, people think that the word bulharzia معناته بول حار. It is not. It is following Bilharz, Theodor Bilharz, which described it. And in a matter of fact, the hematuria which occurs with schistosoma hematobium is not painful. It's not painful. It's painless. It is terminal. It is painless hematuria, and usually is eggs are seen maximally during the midday. And a trick to bring eggs, if you have a scanty number of eggs in the urine, you can ask the patient to warm himself by exercise, a small exercise, to run or do an exercise, and then take the urine. So you can have a high yield of eggs. So it is not Bolhar, it is Bilharzia from Theodor Bilharzia, which is a German physician. And it was noted that there are two types of eggs. The one which has a terminal spine, and you can remember T. T is terminal spine, hematuria, and hematobium. So the hematobium from the T produces hematuria, and the urine contains eggs with terminal spine. So you remember it with the T's. Manson, also working in Egypt, okay, you remember Manson, he described the vector of lymphatic filariasis in China as mosquito. He did that trial of having his servant with lymphatic filariasis. He made him to live within mosquito full of, with a net full of mosquito, and then he described that this is vector. Okay, Manson in Egypt in 1893, he said these two eggs are coming from different species. And he could demonstrate that the worm, which produces the lateral spine, comes from a worm that is living in a different area from the bladder. It is living around the colon. And this is how he described the schistosoma, which then carried his name as Schistosoma mansoni. The name was not coined except in 1907. In 1907, by somebody who said, well, what Manson described, 15 years ago should be honored by naming the worm as Schistosoma mansoni under his name. Actually, Patrick Manson is considered as the father of tropical diseases. Okay, history then was made in 1917. History was made in 1917 where? In Khartoum. How? The first drug to be used for schistosomiasis has been discovered in Khartoum Civil Hospital. Khartoum Civil Hospital still exists, but now it has been converted into مجلس التخصصات الطبية, Sudan Specialization Board. The same hospital was built by the colonial power, by the British, and in Amber called 4G, the ward there, a British who came and established the hospital as the first civil hospital. Civil meaning they have military hospital, which is along the Nile, but this hospital was made to treat civilians, okay? And this is Khartoum Civil Hospital, which was inaugurated in 1907. So this man, whose name is John Brian Christopherson, and Christopherson is spelled Christopherson, Christopherson. Okay, he's John Brian, and he was somebody who is brilliant. And he discovered the first drug for treatment of schistosomiasis, and this is tartar emetic. These are antimonial drug. Starter is what is called trivalent antimony. Okay, it's so toxic drug, which at the time being used for visceral leishmaniasis. But the brilliant chap, Christopherson, noted that he was treating visceral leishmaniasis. Some patients have also schistosomiasis. So he noted that schistosomiasis disappeared. So he concluded that this tartar emetic has something to do with killing the adult worm. So what he did is he took 70 patients from the plenty of who have schistosomiasis at the time, and he gave them tartar emetic. Tartar emetic is toxic because it has a lot of side effects. But he described a very important paper, one of the classical papers of science, and he said a poison in small dose can treat schistosomiasis, and that was a hit. Okay, so that is what happened. But he described very schistosomiasis as schistosomiasis, and then he described that it is a disease of children, which it is, and then he described mass chemotherapy. He even foresaw that what we are now talking about, mass chemotherapy, said if all kids are being treated with this drug or other safer drug, then schistosomiasis can be controlled. Now, in this century, we're going back to some ideas of that Christopherson. His granddaughter, who nationalized Australian, came to Sudan about maybe 15, 16 years ago to trace her grandfather's discovery. She came and we had a conference or a symposium. I gave the paper about the drug, this tartar emetic, and the paper which he published. And he was not only a parasitologist. In that paper, he showed that he is a good physician and a good pharmacologist because he said precautions has to be set, side effects. He mentioned all the side effects which are important at that time. And tartar emetic continued to be the drug of choice. Okay, it's then modified into a better antimonial drug, which has less side effects. We're still using pentustam, okay, which is a relative of tartar emetic. It is pentavalent, 5-valent, okay. Pentustam in Kalazar, still drug of choice in Kalazar, or one of the main drugs. So the tartar emetic continued to be the drug till, it is then converted into Astiban and Bilhar, and then we reach Prazaquanti. So that's about the history. But the important history is which I have been, with all humility and modesty, as I've been allied to, I've been blessed with the group of which put on the literature the importance of ultrasound in detecting liver disease, of schistosomiasis. The morbidity of schistosomiasis was only judged by the number of eggs at that time. Okay, and then the liver is being affected, people vomit blood, and due to high portal pressure, and then they die. Okay, we do postmortem, we find the liver, we can cut it across, we can find fibrous tissue, it's scattered in the liver, like a stem pipe, the pipe al-kados. If you take the bigger part and then the stem of it, clay pipe, because this is whitish, and if you put this into the liver, you can get what the periportal fibrosis look like. If you read the books, they always quote it as clay pipe, stem clay pipe, liver fibrosis. The ultrasound, when it was introduced in 1982, and as I said, that is the first time it was introduced in Sudan. I had an idea of how ultrasound can help because it made a revolution. The revolution which was made by ultrasound was even greater than the revolution made by MRI and CT because it's very simple, it's non-invasive, very non-costly, okay, and it can be portable, it can be moved from one area to another. So I was interested in getting a modality of investigation which will help recognizing the periportal fibrosis. Why? When I came from England, I was interested in schistosomiasis, and I quite often use liver biopsy to get an evidence, histological evidence that this liver is affected by the periportal tract, which is schistosomiasis. We go inside the liver and we come out with a piece like liver biopsy, which is procedure, invasive procedure, needs some precautions. But we used to do it skillfully. But one day, the liver may have been shrunken, and I went past that tail of the liver, and I went into the gallbladder. And then when I sucked bile, and that caused biliary peritonitis. We rushed the patient to the surgery, and luckily he had cholecystectomy and he survived. Since then, I have been thinking about when we introduced the ultrasound in 1982 in Sudan, then I started looking in the liver and how we can describe it. And then went on with the outlining how the periportal tract will look like, and then we graded the degree of periportal fibrosis from grade 1 to grade 3, and then we could even see the varicose vessels with the ultrasound, and then we took it to the field. This is why the beauty. We took a portable machine to the fields of Jazeera, and then we described the morbidity in the field, not only of the liver, but also of varices. So this is an important history of schistosomiasis in the Sudan, and this work has been recognized as a textbook medicine in Harrison, which is being referenced in Harrison with the role of ultrasound, and they refer to our group in Sudan. This is something which need to be remembered. So that's the history of schistosomiasis in Sudan has to remember a professor called Abdul Hamid Said Omar, who did the prevalence in Jazeera, to Professor Saleh Yassin, who did a lot of clinical trials, and he outlined the role of eosinophils, Professor Dawood, and then Professor Ahmed Mohammed Al-Hassan, who did a lot of postmortem, and Professor Isam Attoum, who described quite a lot of this work, and those other interested in schistosomiasis is Asim Dafa'allah and Suad Suleiman. They did a lot of work. Asim, especially in the Blue Nile, and we really have to consider, not only consider, but mention with great respect Professor Ahmed Ayoub Al-Gaddal, who has been the director of the Malaria Center in Sinnar, and when he was successful, he moved to Blue Nile Health Project, or the Blue Nile Project, which controls schistosomiasis, bringing it down from 52% to only 7%. That is Ahmed Ayoub Al-Gaddal, who ended as a professor of public health in University of Sinnar. Okay, because the topic is still on, I would like to spend the last 5 minutes in some of the features of the disease. It is a disease of children. That has to be said from preschool age, from 5, 6, 7 to 18. Okay, and if you draw a graph, if you draw a graph, then the intensity and prevalence will go like this. I don't know if you will see, but this is what it is. Okay, it goes up to that level. Okay, it goes to up that level. It starts from here, the young age, and then goes up, peaking like about 13, 14. This is the peak. This is both intensity and prevalence. Intensity meaning heaviness of the parasite, and prevalence meaning even if you have one case, then this is counted. So both prevalence and intensity, the disease is of children between preschool to about 18 here. And then it goes like that. Okay, so the peak is about, say, 10, all right? But the peak of the complication of the liver disease is about 35 years of age. So it takes about 10, 15 years for the complications of schistosomiasis appears, okay, which is periportal fibrosis in cases of Manson-White. So what is the importance of this? The importance of it being a disease of children, meaning that the children will go not only defecating and urinating, but swimming. So they contract a lot of disease. And this is what we have seen along the Nile, White Nile, in Al Azuzab area, and that other area, and in Sherganil area, Silet irrigation scheme. Okay, it's a disease of Khartoum North, Faki Hashim area. These are the areas where it's heavily infested in children. So the importance of it is infection can perpetuate because children habits are not easy to control. Number two, the disease also appears in children, the complications comes later, meaning that the child receives a lot of infection along the years for 10, 15 years for a complication to appear. Okay. Thirdly, as far as control is concerned, this is important because I could just target school age children or school children. There is a difference between school children, meaning these are the children in the school. But in areas where people don't go to school, we call it school age children. This is why if you just go to the schools, you will miss those who have the same age who are not coming to school. So if we concentrate on the school age children, distribute prazoquantil regularly, then you are going to reduce 65% of the bulk of schistosoma eggs excreted in the canals. And more so, it is important because if it is in the schools, it is very easy to treat the children because they are all there. You just ring the bell, everyone in this class, and then you get water and prazoquantil, and then you give it to individual. All the schools will be given in one day. So you are treating the schools, and this can be done every 6 months or every year. Then you reduce remarkably the bulk of schistosomiasis in the community. So it is being used, this fact being used to construct and outline control programs. And because the disease of children affects children by anemia, stunting of growth, and cognitive effect. So the children would not do good in the schools because of schistosomiasis. Okay, so once you treat the children with prazoquantil, then their performance will be better, their anemia is corrected, and they live better life. So it is important to bear that this is a disease of children. So, symptomatology of the other part of the disease, which is mainly Manson-I, the pathology, and then we come to the the presentations, which can be acute, which is rare, not common in endemic areas, or chronic, which is hepatosplenic schistosomiasis, and we will come to that in the next lecture. So this is the first part of schistosomiasis. I hope it has been of some importance or some benefit to your knowledge. And next time we'll see that it is not just a disease of physicians. It is a disease of gynecologists, surgeons, urologists, neurologists, okay? All these have patients who have been affected by the granuloma because the eggs can get out in the blood, and then there they can go anywhere in the body until the skin. The skin granuloma of schistosomiasis has been described in the skin. So it goes everywhere in the body and then causes granuloma and swelling and then fibrosis. I just want to close with a story of a patient who have orchitis, big testicles. It felt like carcinoma. And at that time, people didn't have ultrasound and the rest of it. And the surgeon felt the urge of this is seminoma or carcinoma of the testicles. So he took it out. And when it was cut, it was full of granuloma of schistosomiasis. So a man lost his testicles because of misdiagnosis. So this brings home that schistosomiasis can simulate quite a number of diseases. Okay, with that, I would like to close and thank you very much for being with me. I intended to give it in details because I would like this lecture to circulate to the other universities and other students because this is something which is very near to my heart, and I would like to explain it to the young generation. Thank you very much indeed. Bye-bye. Okay, ساعة.